So we'll just give it a minute or so to let folks into the webinar, and we'll get started.
I may be controlling this currently, so you may want to switch it over to.
Okay, I think I have control now, which seems to be working. Carrie and Deborah, you just want to let me know when we can get started?
Great, I think you can go ahead and get started. We've got attendees on, so
okay,
feel free.
All right, well, thank you, and welcome everyone to this evening's MSTS webinar, where we will be discussing tumor resections and reconstructions using advanced technologies and the pros and cons, and giving tips from the experts. And so my name is Justin Bird, and I'm excited to moderate this session. And I look forward to some exciting talks and the Q&A. Just for those who have questions, please use the Q&A area there. You can submit questions throughout the session. We will have some time for Q&A where we can address those questions, but we will also be reviewing them during the talk. So the panelists, if there's any answers that they may want to provide during the sessions, we will try to answer those questions in the chat as well. I will start out with our intro, and then we'll introduce our panelists and hear their talks. This is my disclosure slide. I do want to thank my entire department. This is obviously a team sport here, and so I really appreciate the collaboration in my department. This is our group of panelists. We have Dr. Calderon, Dr. Coleman, Dr. Albergo, Dr. Marichli, and Dr. Tappa, and I will moderate, as I said. Tonight's purpose, we really want to ask kind of fundamental question. Are these technologies helpful? And we're talking about advanced technologies using computer-assisted design and planning, navigation, 3D printing, augmented reality, and virtual reality. And what kind of role do they have in cancer surgery? Are these things nice to have? Are they necessary, or are they a waste of time? And so we'll talk through these issues. I did want to kind of just, remind us, where we've come. If you think back, many of us remember running down to the film library to grab films for cases and then throwing them up on a light board, and then doing templating on that and trying to prepare for these surgeries, drawing on the films, and then taking those into the operating room. But today we have, computer software that we have digital films, and so it makes it much easier to create really sophisticated plans. We also have to recognize that much of what we do now is related to advances in imaging. And so if you think of where we are with MRI technology and CT, we're able to get really great detail on the anatomy, and that helps us with our plans, obviously. And then image segmentation is part of this process, where when you get these these sophisticated images, you can then break down the different pieces of the anatomy, and obviously that's going to be important in terms of developing a surgical plan to resect a tumor in a tough spot. I did want to also mention that much of what we're talking about is also related to the 3D printer and the STL file. And so this was really invented back in the late 80s. And this really spawned a tremendous amount of innovation that has hit so many different industries. And here you see an example of a 3D printer, but it really, the language that it is using to do its work is the STL file. But you know, we're cancer surgeons and clinicians. So what does the STL file have to do with tumor surgery? Well, as we think about what we're doing in these surgeries, our goals simply to remove cancer and to optimize the quality of life and function. But how do you really do that when you're dealing with some really difficult problems and sometimes what we would term, or I would term, a wicked problem. And this is an example of a wicked problem, and that term comes from the 70s with Horace Riddle and Melvin Weber, who were social scientists, but they defined it in a number of ways, which I think are applicable to some of the things we do. And particularly, there's no way to test the solution for the wicked problem, and every solution is a one-shot operation. And here is an example of an X-ray of a patient who has, I think, you know, one of these type of wicked problems. He had previous surgery for a dedifferentiated chordoma. These are the MRI and CT scans. It spans multiple levels of his lumbar spine and encases his spinal cord. He's lost, you know, bowel bladder function, can't walk, and in a lot of pain, and he's had previous treatment. So what do you do in this case? And that's an example of a one-shot operation. And we really, you know, all of us, I think, do our best to, you know, help a patient. And we ask ourselves a lot of questions, and that's part of that process. And you know, trying to figure out a way to help. And a number of these questions we have to answer before we even get into the operating room, right? And that's the surgical planning process. And it can get very complex, but I think when you break it down and you just think, you know, the goal is to help, simplifying the steps, I think, has made it easier to you know, tackle some of these really difficult cases. And so that's what we did for this particular patient. And you know, we'll get into some of the details of the surgery and some of the technologies that we use for this. But this is the tumor coming out en bloc. And so, you know, I think, again, when we're addressing these really tough problems, surgical planning is critical. And so let's really just jump into our discussion for today with our panelists. And I will introduce Dr. Santiago Lozano Calderon. And I will just mention he's a friend, but also a great colleague. I did pull some of his information that we could kind of quickly mention, that he earned his degree in Colombia. He has a PhD as well from the Netherlands. He's trained and at New York and Valhalla, as well as completed his fellowship in oncology at Mass General. So we're going to turn it over to Dr. Calderon and take it away, Santiago.
Great. Thank you so much, Justin, for the kind words and for organizing this. It's great to see colleagues, friends, and see everybody at least virtually. Thanks for joining, and I hope that all of you are doing well. So I'm going to discuss briefly computer-assisted surgical planning for tumor resection and some of the other techniques that go along with this technology. These are my disclosures. Basically, a computer-assisted surgery is the field in which you try to involve machines and computer science in the development of improving surgical techniques for surgeons. The theoretical benefits are improved precision, improved control, more flexibility, and there are different ways or modalities in which this works, which range from visual assistance, mechanical assistance, and help with navigating or performing the surgery. In terms of history, this was first developed for location of brain tumors and stereotaxic surgery. All of us are aware of the Da Vinci robot in orthopedics. There are big strides in arthroplasty, in spine surgery, and we're going to see a little bit of that, but we'll focus in oncology. So there are different subtypes of assisted or computerized assisted systems. There are passive systems such as navigation, in which all responsibility of movement comes from the surgeon, semi-active systems like the Mako robot, and active systems in which the actual machine performs all the movements without the help or input from the surgeon. These techniques have current use in hip arthroplasty, for example, especially rimming of the acetabular cup and planning of the femoral neck cut for improvement in limb length. In knee arthroplasty, it has changed the paradigm of knee balancing, and it assists in the femoral and tibial cuts, taking out of the equation the soft tissue balancing from the surgery. In shoulder arthroplasty has helped a lot in the planning of the glenosphere, insertion, and in spine surgery, mainly in pedicle screw placement and correction on deformities. A lot of work has been also done in tumor resections. In trauma surgery, it has been used for minimally invasive placement of periacetabular fracture reduction, navigation of sacroiliac screws and hip screws. But what about orthopedic oncology? It was in the late first decade of the 2000s where we started to see patient reporting on this. Professor Grimmer in England started to report it on the resection of periacetabular tumors and the use of custom-made devices. In this setting, they use either custom guides or navigation, and they reported really good outcomes on that. One of the most interesting cases is this one reported by Wong in Hong Kong, in which they use fusion technology to help in the navigation surgery, including into the planning the soft tissue component of the tumor. But really, Doug Letson was the person that really started to develop this, and he has the first really consequent and large series of 20 patients with resections in different locations, obtaining negative margins using this technology of fusion of the MRI and the CT scans. Dr. Wong also developed this technique for joint preserving resections, and this is a big field in orthopedic oncology. A group in Japan compiled a series of 16 patients and assessed the benefit of using the navigation, also demonstrating negative margins and no local recurrences. This experience has been reproduced in England. I think Lee Jace and Professor Grimmer are one of the most productive groups on this, and they have short-term and long-term outcomes study. This is one of the first ones in which they were assessing the short-term outcomes, in which they report all clear bone margins and no recurrences. A big part of the use of navigation is in the pediatric population, especially trying to preserve the growth plate. This is the experience from the People's Republic of China Hospital. And then there have been a series of different review papers in which different institutions report on their series, and all of them basically say that you can get a negative bone margin and you can get more precision when you compare with your historic data. This is one of the papers that first look at the learning curve. This is Philip Funovics, but the number of cases is not enough, in my opinion, to determine a learning curve. And Dr. Albergo is going to discuss more of that in a lot of research that he and his institution have done on this. Navigation has become really important in resection of pelvic tumors and sacral tumors. I think this is a very good paper from David Geller that shows the problems that can happen with this surgery that is less invasive. Two of their patients had a temporary femoral nerve paralysis. This study from Dr. Lee Jace, excuse me, talks about the long-term outcome. And I think this is important because this is the first paper that shows really an impact after 5 years in terms of local control of pelvic tumor resections using navigation. One of the other devices that is being used is the custom-made guides that are basically created with computerized plans. And this is the group in Belgium reporting the experience with 11 consecutive patients, and they demonstrate very good accuracy when they compare with historic cases and when they compare the resections that they did with the final CT scan after resection and the preparative planning CT scan. As you can see, all the margins here are negative. This is an example showing the cutting guides and how they sit down over the exposed bone. Sarah Bosma from Leiden did a very interesting cadaveric study comparing freehand techniques navigation and the combination of navigation with these custom-made guides, which at some point I thought was going to be the solution for this problem. And what her group ended up demonstrated was that the combination of the navigation and the guides, it just increased the surgical time. It didn't change the accuracy of the resections. And you can see a graph of that here. Later on, they published their experience with a very good matching study in which they compare their historical resections with ones using navigation. And I think the importance of this study is that this study is the one that shows that navigation is very good to get negative margins in terms of bones, but it's not good to get a soft tissue margin to be negative. This is again the group in Belgium reporting their experience with the cutting guides, and they basically report negative margins in soft tissue and in bone. 3D printed technologies go hand in hand with this type of guides and with navigation. This is the largest series that has been reported recently. This is the group of Weigo, 80 consecutive patients, and is really impressive, the outcomes that they get, no aseptic loosening, a very low infection rate, and very low dislocation rates. And they just conclude like how these technologies and the volume has helped them to really master these resections and techniques. One type of device that we don't have here in the US or that is not that popularized in terms of use is the ice cream cone prosthesis that's mostly used in Europe for pelvic reconstructions, and navigation also can help to aid in the placement of the stem, which is crucial in this type of reconstruction. This is the experience from the group in Croatia, a series of 11 patients in which they use also custom-made 3D printed guides for pediatric population, doing also very good resections and very good oncologic outcome. One of the uses too is that you can use navigation or the guides to make the cuts of your allografts when you're doing reconstructions. There is a different series on that show increase in the surface contact between the reconstruction and the host bone. This is an experience by a group in China in the pediatric population addressing the same periarticular resections in which preservation of the growth plate is important. The Italian hospital in Argentina has a significant experience with this, and Dr. Albergo will be elaborating on the use of navigation and allograft reconstruction. But I think their paper is great, and the landmark paper is great because it addresses a lot of the difficulties that I have seen in my practice that I didn't see reported in other studies, which is that sometimes the thing just doesn't work and you cannot do it and you cannot do the surgery, and that it increases the time, and you have actually a relatively high complication rate sometimes, and is not necessarily better than from what you were doing before. it also highlights that it increases the surgical time, and in pelvic surgery, that's of relevance because of the infection risk. David Geller did a very nice study using navigation, trying to increase the surface area of contact between allografts and the host bone, getting good theoretical results in a theoretical improvement in terms of the reductions of non-union that are observed with traditional techniques. The learning curve is a hot topic. We'll be discussing this later on, but this investigation from the Italian hospital, again in Argentina, shows that really with experience, what you decrease is the time in performing the surgery, but the accuracy actually doesn't improve over time. There is a lot of discussion on this, but I think part of the issues is the volume that each institution has on that. Lately, the hottest topic has been the combination of all these technologies. This has been the big thing for LeJs. They report shorter operative times. They report lower infection rates, and they report very better incorporation of their 3D printed implants just because of a better fit of the implant by combining the navigation and the cutting guides. The fiducials are a pain in the neck. Some systems you have to put fiducials in bone, and that's very difficult sometimes depending on the location of the tumor. This is a nice study pilot that Dr. Conrad led, and is basically assessing the efficacy of skin fiducials, and the results on that are promising. So the limitations with all these techniques is that they increase the preoperative time for preparation and setting time. You need to invest the time to acquire intraoperative images. You have to spin with the arm, and that increases your surgical time. There is the big question mark of cost and running expenses, and the question of how many cases you have to do to really reach cost effectiveness. A big deal, excuse me, is the use of this for soft tissue margin. I think fluorescing and dyes are important for this. And the navigated guides can, excuse me, help to increase the surface contact. I have to get tested for COVID now.
Need a drink of water?
So just have a scotch here. So there is a thing that is called haptics, that is feedback from the machine when you're using or positioning your hand, and that's very useful, like in the Mako. I think we have to use that in orthopedic oncology at some point. And just to conclude, some food for thought, there are different studies that are finally starting to show the benefit of robotic surgery, but that includes thousands and thousands of patients that I don't know we're going to be able to get in our orthopedic oncology population. Thanks for your attention.
Thank you, Dr. Calderon. That was a great review, and we're going to jump right into our next talk by Dr. Coleman. Dr. Coleman is at Rush University, and he is a orthopedic oncologist as well as a spine surgeon, and I love to meet and work with people like that. We will be hearing from him on some interesting, exciting technologies using augmented reality and virtual reality in orthopedic oncology. So I will turn it over to you, Dr. Coleman.
Thanks so much, Justin. I really appreciate you having me, and thanks to the panelists for joining. It's a great cast of characters, and I've looked through the attendees. I think some of the attendees know more about this stuff than I do. So appreciate everybody being here, and hope we can have an interactive session. Disclosures, I just have one sort of relevant one. I have a little bit of equity in an augmented reality company called Augmetics, otherwise not relevant. So I wanted to start, augmented reality and virtual reality are sort of this, for many of us, like a black box sort of definitionally concept. And so I want, one of the things I want to walk away from this talk with is having a little bit more refinement in people's understanding of what these technologies actually are in their essence. I'll sort of try to talk about what the current state of the union is and sort of what's coming in the future, because these are very, very much evolving technologies. The first mention of augmented or virtual reality is Milgram in 94 as it relates to surgery. And he said a virtual reality is defined as a real or simulated environment in which a perceiver, the operator, experiences telepresence. So that's clunky, but what it really means is that as I go through my actions in the real world, I interact with electronic imagery that comes to help me or comes to interact with me, and I interact with it. I'd really recommend that everybody read Joe Schwab's review article on AR and VR. This diagram is from that article, and it just really lays out the concepts well. It just came out this year in Spine Journal. And so we just have to understand that our real actual environment and the virtual environment, something that's totally made up by a computer, it really exists on a continuum. So existing within the virtual environment, like with a virtual reality headset, for example, that's on one end of the spectrum, and mostly interacting in our regular life and our operating room, that's a real environment, that's on the other end of the spectrum. And what AR and VR do is help us sort of blur those two environments. And so the more, augmented reality is much more over towards the real environment with a little bit of onlay of telepresence. And virtual reality really has no basis in the real world. But this was kind of a newer term to me when I started looking into this talk. And augmented virtuality is much more of like a virtual reality where you're actually able to manipulate objects and have tools that are real that work with that world. So we just have to understand this continuum. The definitions are not rigid. It's sort of, again, an evolving and blurred topic. I want to start with a little bit of augmented reality topic. So this is, again, augmented reality is I'm existing in my actual world, but I'm overlaying image information into that world to help me. So, currently there's a lot of AR stuff going on. There's basic science studies, and I'm going to show you a few of them. There's laboratory testing. Certainly education and preoperative planning before you do surgery. But I will submit to you that AR is in our operating rooms. It is in play right now. I use AR for almost every percutaneous pedicle screw case that I do. And I want to show you a little bit about how it works. And I brought a case to show. I think in the future, augmented reality, there really is no limit to what it can do. If you imagine any sort of electronic onlaid data to your operating room, whether that's an arrow, a pointer that's indicating where you should cut, or anatomy that you just can't see around the corner, or whether it's actually your buddy Santiago chiming into your headset and saying, no, stop, don't do that, do this, and he can show you in your visual field what exactly to do. This is what's coming in the future. So I really think it's an open source technology that's not limited by the technology itself, but only by sort of what we can imagine it can do. And so, to any augmented reality system, there's sort of three components. You have to be able to somehow link, you have to be able to track the patient's anatomy that you're working on. So there has to be some way for an optical scanner to understand the patient's anatomy and then link that up to your display that you're seeing. And you also need a computer to run it because this is pretty high computational power. So just as an example, this is a patient had clear cell chondrosarcoma with 2 metachronous metastases. So the patient had a big proximal humerus resection, and then a couple years later had a big cervical spine resection and a C7M block, and actually had a good disease-free interval for about 12 months until he developed back pain. And he came in with this sort of obviously worrisome but innocuous, nothing too crazy, but a lesion in T10. And we sent him for an IR biopsy and it came back nothing. Sent him for another IR biopsy, it came back nothing. So we're kind of stuck. I know in my heart that this is not something great and it's probably his tumor back, but I have 2 negative biopsies. So I usually take people to the OR at that point. And I want to show you how I use the augmented reality. So that's That's me with the headset on. I'm putting a Jamshidi needle under image guidance into the pedicle and steering the trajectory right into that lesion. And at its essence, this augmented reality that I'm using today is really just navigation with a heads-up display. Everyone's familiar with these two sort of navigation displays, but what's different about it is this bottom part of the screen. You can see that little sort of like X-ray vision halo. Before I even make an incision, I can see through the skin and I can see in 3 dimensions what the bony landmarks are. I can set the trajectory for the Jamshidi needle, and I can really be very, very precise about what corridor I take into the bone. So here, these are just sort of some screen grabs from like what it looks like on the display monitor for everyone watching in the operating room. You can kind of get right into the lesion. You can see your surface bony landmarks on the 3D model. But again, as the operator, you're really seeing this, that 3-dimensional image. And I wanted to show this picture because when I have a negative IR biopsy, it's usually because the tumor is a little liquefactive and there's nothing coming in the trocar or the trephine trocar. So I use like a little alligator, like a micro alligator forceps to actually grab tissue out of the bone. And you can actually, this is similar to like a stealth sure track. If anybody uses stealth navigation, you can just basically navigate any instrument as long as you can mount a tracker to it. So I was able to mount this alligator Jamshidi. I was able to mount a trephine, the tracker onto a trephine and do the biopsy that way. And we got him the diagnosis, which unfortunately was not good. So hopefully that gives you a sense for how I'm using that technology today, but I hope I'm also making the point that the limits, there's really no limits to what augmented reality can overlay onto your actual world. There's not much evidence clinically out there for it, but there's a lot of lab stuff. This is a study from a few years back, which used a bone cement model in a porcine tibia or porcine femur. And they can basically use these optical trackers to just sort of overlay the image for the surgeon based on preoperative imaging. Hey, you got to cut here and here. And that led to a more accurate cut. This is another form of AR. It's actually like a tracker and a video projector. So as you shoot it, as you point it at the bone in question, it projects where the tumor actually is inside the bone. This is obviously a lab study, so kind of cool. And also just an example of a biopsy trajectory with AR. So you can see as you go to put the biopsy needle in, it gives you a target and it gives you a trajectory and it tells you exactly how to do it based on your preoperative planning. And here's another study, which is just a pig pelvis model with cement simulating a tumor. And this is an AR overlay that's attached to a saw. So you get to see where this theoretical tumor is and use the saw accordingly to stay away from it. And that achieved very, very accurate margins compared to a conventional resection. So I think some of the other disciplines in orthopedics outside of orthopedic oncology have done an amazing job with incorporating AR. This paper from Fatuhi was actually a really neat study where, based on preoperative planning and using an AR overlay of the acetabulum in surgery, you can just see a picture of like where the ideal position of the cup should be, and therefore you implant the cup that way. Anybody who's doing spine surgery is sort of interested in the interaction between hip and spine and where we should be putting acetabular cups in patients with spine fusions. And so this has really captured my imagination that you could just overlay this ideal position in surgery. We all know that the external jigs are pretty inaccurate as far as cup version. So pretty interesting use of AR. Sports medicine has demonstrated some sort of interactive remote teaching during surgery. So like an instructor can overlay images during your surgery to tell you kind of what to do or what not to do. This trauma study was pretty interesting. You can AR overlay like an ideal plate position on a pelvis based on the pelvis being virtually reduced, and therefore bend your plate and create your plate to fit the ideal reduced position, and therefore use the plate to reduce the fracture. And then AR is all over spine as far as instrumentation accuracy. So what's the downside of AR? You might be tempted to pay more attention to the actual image overlay than what's going on in the actual surgery. So that's could be a potential problem. People do get motion sickness from it. I've never had that problem, but you know, in its current form, AR is very much a navigation technology. So that comes along with all the registration and accuracy problems that we face with navigation, and then certainly cost. I want to talk a little bit about virtual reality now as opposed to AR. So we're going to the other end of the spectrum, and we're talking less about the real world and more about this virtually created world. So the user really exists within a fully developed interactive environment. And this technology is absolutely driven by gaming. Anybody who's put on an Oculus headset, this is what I'm talking about. It's really a tremendous experience. If you've never done that, find a friend that has one, because it's very, very cool. And your imagination will definitely run wild with what you could be doing with this in surgery. So in its current form, it's really not in the operating room as much. It's really used for preoperative planning and education, and surgical simulation as well. But you can imagine that that in its future form, I think the holy grail of virtual reality is telesurgery. So I could sit in my basement in my gaming console, and I could actually operate in a virtual world, whereas where a robot is actually doing the surgery in a distant location. So that requires a lot of internet bandwidth and obviously a lot of robotic technology, and we're not there yet. But I think that's kind of where virtual reality is trying to go. For now, I wanted to show you how I would use it in real time. This is an actual case. This is a MHE patient with a chondrosarcoma of L2, kind of coming off the facet and transverse process. Some more images of it. So in planning the case, I actually, and I can't put an Oculus headset on everybody, but this is an actual virtual reality video that I took of this patient. So the headset's on me, and I'm in my office, and I can actually go inside the image, and I can spin it around, and I can look at every single angle of this tumor and try to understand like where it's attached and where it's not. So this is preoperative planning. It's like a fancy 3D printed model that I can go and zoom in on again and drive around. So very, very cool. This is all driven off an Oculus headset. So just an example there. Evidence of virtual reality is also really limited. This is like a pedicle screw simulator study that used haptic feedback, and they showed that when they put students on this simulator, the students got more accurate and had less standard deviation in how they put in pedicle screws. This is a brain tumor virtual reality exercise. I thought this was fascinating because they had a bunch of different operators of all different levels, and they had them do a simulated brain tumor resection. And actually the machine learning that they were running was able to detect how experienced the surgeon was based on what kind of moves they made in the simulator. So kind of neat. And then just another study looking at virtual reality and planning periarticular resections. The authors, it was just sort of an observational study, but they noted that the resolution of the imaging is super, super important. If it's bad imaging or not thin slices, it becomes hard to do the simulation. And also, we just aren't there yet with our virtual tools. So if I'm doing a simulation of a bone resection, we don't have the good technology to simulate a saw or how an osteotome feels at this point. So all good points by the authors. All the same pitfalls with VR, you can get this very significant motion sickness from it. It's hard to simulate the actual human touch or the real maneuvers in surgery, and obviously cost. So I think in the future, I talked a little bit about the limitless nature of AR and VR in interacting with our actual real surgery environments. I think we need to figure out ways to incorporate it safely more into clinical study. We need better clinical data. We need to develop virtual tools that actually simulate our surgical maneuvers and not just sort of imaging based virtual reality. Also, I'll just make a comment that right now, all this navigation technology is really run off intraoperative imaging acquisition. So you need a big O-arm, you need a Zeem image acquisition system, which is a lot of capital cost. But I think right around the corner is running this stuff off of preoperative imaging, like a pre-op CT scan, and registering in the operating room and being up and running without all the fancy technology. So my favorite kind of technology is technology that's elegantly untechnological, and works well without a ton of different equipment and machines and expensive tools. So I want to thank everybody again for the chance to speak on this, and we'll answer questions as we go. Thanks.
Thanks, Matt. Really appreciate the talk, and a reminder for everyone to, if you have any questions, please put them in the Q&A, and we'll get to them. I was just going to quickly ask, Matt, have you noticed any difference? You mentioned, the issues when you put on the headset and some people getting seasick. Do you know, is VR more, is that more of an issue in VR versus AR?
I think so. But fortunately the VR, yeah, I've definitely gotten queasy with the VR. Fortunately, the VR is not really in the OR, I don't think, at this point. So we won't be getting sick during surgery. But yeah, when you get into that virtual environment, it can be very disorienting. The other thing I'd say is that the AR headsets, like, they're not perfect because I can't wear my loops with them. You have to like kind of take your loops off and then put the headset on. The lighting isn't as good. So the technology will come, but it's evolving for sure.
Thank you. All right, let's jump into our next talk by Dr. Abrego from Buenos Aires, and really appreciate him joining us tonight. He's a consultant in the oncology unit, specializes in allograft reconstruction. He's also the head of the amniotic membrane transplantation team, which is pretty interesting. And he did his fellowship in Birmingham and another fellowship in the Netherlands. So we are looking forward to your talk. Dr. Abrego, take it away.
Thank you very much, Justin. Thank you very much for the invitation. So now we are going to talk about a bit of indications and learning curve in computer-assisted surgery. So this is, I have no conflict of interest to declare. So what we are going to talk about mainly, we are going a brief resume about history. We are going to talk about how we do cast surgery, which were and which are the problems that we usually face with navigation, and which are the indications that now we select the patient for this technology. So the use of cast become very frequently in orthopedics. We have wonderful talks about Santiago and Matthew. And in orthopedic oncology, mainly the goal of this technology is to be accurate in resections and to try to reproduce as we plan the margins of the tumor. We know that in general, in orthopedic surgery, there was varied acceptance. Now they started using this technology in arthroplastic and in spine. But for orthopedic oncology, we had to say that we really like this computer-assisted surgery because they help us to be accurate in resections. And probably the most important thing in oncology is to achieve free tumor margins. So first, this technology was initially used in spine and pelvis, but extend to the extremities. And for us, it's very useful to use cast in extremity tumors and extremity tumor reconstructions. So if we are going to talk about computer-assisted surgery, we need to go back to 2020 years ago, where Aponte Tinao, our chief, developed the first part of the beginning of this computer-assisted surgery that was for us the virtual bone bank. He worked on that, and mainly what he changed in our hospital was we used to select the allograft with X-rays or with CT scan, and what he developed was the software and the plan to digitalize all our allograft, and through a mirror image in the healthy contralateral bone, try to select the most accurate bone in order to reproduce the anatomical surface and the anatomical characteristic of the patient. So this was done after a couple of years of working, where all our allografts were scan, CT scan, and 3D reproduce, and then the software select that allograft that really match with the patient. So this was the first step, or the beginning of our computer-assisted navigation surgery in our hospital. How we perform is something that probably we all know, but navigation helps us to reproduce our main goal, that is what we plan outside the theater, to reproduce that in the operation room. So all start with the image fusion. We use CT scan and MRI to try to build the tumor volume and the bone virtually. And then the second step is what we call the virtual preoperative planning. And this is probably for us the most important part of the surgery. Here we define the 3D model of the tumor, we define the tumor extension, we plan the margins that we are going to do and how we are going to resect the tumors, and we plan our osteotomies. And probably that time that we spend discussing and working with the team, looking for the better margins or the better resection, is what helped us to reproduce or to plan the surgery before we go to the OR. Definitely for us, this is the most important part of this technology, to work together and to define the margins in a virtual scenario. The third step is that is the navigation. Probably we all know this is the computer-assisted surgery with the trackers, the registration part, the osteotomy that we planned previously. But this is something that most of us know, and this led and allowed us to do a guide resection, and after doing the resection, allowed us to check if that resection is just as we planned it before. So this is a very useful tool for us, not only for spine and pelvis, but also for multiplanar osteotomies in the extremities. So this allowed us to do not only the resections, but we also help us to plan and to do the reconstructions in the allograft. So now we are working with two teams at the same time. One team is doing the resection part, the resection of the tumor, and the other team in the OR, also using this technology, the computer-assisted surgery navigation, is doing the reconstruction in the allograft. So this allowed us to plan not only the resections, but also the reconstructions. The virtual planning, as we all know, is the first part of this technology. Then inside the OR, we do the registration. We expect an error below 1 millimeter. And then we navigate our osteotomy previous plan in the virtual scenario. And something that we have learned is that when we use, and you can see in this drawing, the blue part is the allograft, the green part is the tumor that we resected or we planned in this virtual scenario. And we realized that every time we do a resection, we lost a little part, 2 millimeters in each side, because of the saw movement. So we always plan our reconstruction in our allograft a bit bigger because of that 2 millimeters that we are going to lose because of the saw movement. So this is the image. We see the allograft is always a bit bigger than the bone we resect. So this is, so in 10 years of experience, we started with this in 2010, which were the intraoperative technical problems that we have with computer-assisted navigation. Something was already mentioned by Santiago, but mainly in our first 12 months of experience doing CAS, we have 4 main problems, let's say, where 2 were related with software problems and 2 were related with hardware problems. The 2 related with software problems, one was because we use a Spanish letter that was not allowed or was not recognized by the software, something that when we start doing this, we don't realize. And the other 2 problems we have were hardware problems and mainly related with trackers. Nowadays, we go to the theater with 2 pairs of trackers in order to try to avoid these problems. But we saw that all these problems occur in the first 12 months that were related with our learning curve. This is something that Santiago also mentioned, that the accuracy in the system is independent about the time or the experience we have. There were no relationship between the learning curve and the accuracy of the system. But yes, we found and we see a significant difference in the time we spend doing navigation. And that is something that we all expect. The more we do, the better we become, and the less time will demand for us. So surgical time is related with our learning curve. How we modify our oncology resections mainly. Initially, we go to theater, I think as we all did, with the X-ray, the MRI, the CT scan, and during surgery, we were discussing or planning what to do, looking to the images. Nowadays, we plan all the resections virtually in a previous scenario, and we go to the theater with the osteotomy already defined, and navigation guide us where we had to do. No more discussion, no more speculation during the surgery. We reproduce what we planned previously. In which procedures do we use CAS in the last 10 years? Mainly in three groups of procedures: intralesional resections, pure en bloc resections, and en bloc resections plus allograft reconstruction. We have to say that for intralesional resections, we use it in a very few cases, just 5% of all our 200 cases, and were only for benign tumors and one low chondrosarcoma. The indications were really limited for these procedures, and if we had to highlight a positive aspect, we will say that in none of these cases we use intraoperative X-rays. So really, the use of navigation in our group for intralesional resections is limited. We use it for some difficult curettage in tricky anatomical zones that could be the pelvis or the spine, but really it's not our first indication. Around half of our old cases that we plan with computer-assisted surgery were en bloc resections for mainly all bone sarcoma or aggressive benign tumors, and more than 50% of them were in the pelvis. We saw that all our tumors margins in terms of bone were free, but we had 3 positive margins in soft tissue, and I think that this is probably one of the main problems nowadays with navigation, that we cannot control the resections in the soft tissue. The average and the percentage of local recurrence was not much different than we published previously. Probably we need more time to analyze this. And this is an example of a chondrosarcoma, zone 2 of the pelvis, multiplanar osteotomy to resect it, free bone margins, and then reconstruct with a total hip prosthesis. Or we use it for some benign tumor. This is an osteoblastoma in the anterior cortex of the tibia. We decide to do a guided navigation for an en bloc resections. The third group of patients where we indicate the use of computer-assisted navigation were the en bloc resections plus allograft reconstruction, and these were exclusively done in long bone tumors and mainly bone sarcoma. And again, when we report our complications in this group was around 30%, not much difference with previous series. Probably the benefit we see in this series were a less number of non-unions. So this is an example, telangiectatic osteosarcoma resected with a multiplanar osteotomy, then the resection of the allograft to achieve accurate reconstruction with good functional results. So this image for us, it's quite important to highlight the 2 teams working at the same time, one team doing the resections and one team doing the reconstruction or the resection in the allograft. This allowed us to have accurate reconstruction. This is an example of a patient with a multiplanar osteotomy. Quite difficult to do it if we don't have the assistant of navigation or as a 3D printing guide. So this is a multiplanar osteotomy. Once we do the resection or one team finish the oncological part of the resection, the other group is working on the allograft, trying to reproduce exactly the bone defects that the patient will have, and we then finish with the reconstruction and the stabilization with a simple plate. So the process of this computer-assisted navigation in general is virtual planning outside the theater, doing navigation of the oncologic resection and navigation of the allograft. So after 20 years of working with computer-assisted navigation, we developed the virtual bone bank. We really highlight the importance of the virtual planning before going to theater or to surgery. We use navigation for the tumor resection, and we use navigation for the allograft reconstruction. We consider that this helps us in terms of precision, in terms of accuracy. We have no doubt that it's very useful in pelvis, and we consider also important for extremity tumors. So final considerations, the success of using computer-assisted surgery in our group was quite high. Only technical failures preclude this technology in 2%, 4 cases out of our first 213. Registration was accurate, no matter in which moment we did it, but the surgical time improved with our experience. If we have to give a main indication, we have no doubt that this for primary malignant bone tumors, for en bloc resections, no doubt pelvis and sacrum. In extremity bones, if you have the experience and the chance, we consider it is important to use it. And for intralesional resections, from our point of view, the indication is limited, and probably the greater benefit would be no using fluoroscopy. We published in 2020 this experience where we could answer the first topic, that is indications, but if we look for better results or really the benefit of navigation, I think we need a couple more of years to see if it really benefits. So to resume, if we could summarize the indication or level of recommendation, we will say that for intralesional resection is slow, for resection plus allograft reconstruction is medium, and definitely for wide resection in pelvis, sacrum, and probably in spine also, the indication of this technology is really high. What we need for a new technology to succeed, probably this is applied for everything, the topics we are going to talk now, to take today, probably the final goal is to be easier, to do our work faster, to have better results, and if it's possible, to be cheaper. Thank you very much.
Well, thank you, Jose. That was a great talk. I really appreciate seeing the experience there. And we're gonna move on to our next talk with Dr. Marichli. Dr. Marichli is a plastic surgeon here at MD Anderson. He's gonna share some of the aspects of computer-assisted surgery for the reconstructive side of things. And Alex, why don't you take it away? I think you're Alex, you're muted. Maybe on double mute there.
All right, now
There you go.
Okay, great. All right, so yeah, thanks, Justin, so much for inviting me to participate in this panel, and I'd like to thank the Musculoskeletal Tumor Society also for inviting me as somewhat of an outsider to this group to contribute. And I do a lot of cases with Justin and the other orthopedic oncologists at MD Anderson, and we as plastic surgeons have also embraced computer-aided design and manufacturing in the reconstructive aspect of these orthopedic oncologic cases. And so I'm here today just to kind of share my experience with that. So I can, how do I advance the slide? Oh, there we go. Okay, so we can skip over that. This is just the background. CAD/CAM for facial reconstruction is really where this technology exists within the field of plastic surgery. And much like in orthopedics, the popularity and the interest in CAD/CAM for facial reconstruction has really increased exponentially over the last several years. As you can see, is indicated by the number of publications registered on PubMed with the terminology of CAD/CAM in the title. And the reason why it's liked really is it's faster. It's been shown in this meta-analysis that we published to reduce the OR time by an average of 65 minutes. It's safe and effective, so there's no difference in complication rates between surgeries that are performed with CAD/CAM and those that are not. And it also facilitates a more accurate reconstruction, which, as you all know, as orthopedic surgeons, is very important, but it's also important in the head and neck from a functional standpoint from eating and speaking and chewing, but also from an appearance standpoint. And this is just a representative case example of a gentleman who, a young guy who presented with T4 melanoma. And in order to have it resected, he needed to have his zygoma or his midface removed. And to reconstruct this aspect of his craniofacial skeleton, CAD/CAM was it was almost imperative in order to get the best, most anatomically accurate reconstruction. And so we use a vascularized fibula flap that we're able to osteotomize several times at very specific, very precise angles in order to recreate his multidimensional facial anatomy. And this is just a video recording of the webinar where we plan this surgery. And you can see here the osteotomies that are being designed. And as we move forward, you can see the area that is planned to be resected and the fibula. This is the patient's actual fibula as taken from a CT scan of his lower extremities, and how we're going to shape and osteotomize that in order to turn his fibula into his zygoma. And this is the static image of the plan, along with patient-specific 3D printed plates in order to fixate the segments. And one of the useful things I wanted to point out that's really difficult to do without CAD/CAM is that we were able to recreate the exact curvature here of his orbit, where we were able to burr out a nice lateral orbital wall to recreate his facial anatomy. And these are just some intraoperative images. Dr. Jeff Myers is the head and neck surgeon that did the resection. And you can see here it is his pre-op and his 1 year post-op image. Arguably, he might even look better after his cancer resection and reconstruction. Most commonly, CAD/CAM is used more for mandible reconstruction, just because those types of resections are more common. And we most commonly will use the fibula for that, at least at MD Anderson. But in other institutions, the scapula is also used for mandible reconstructions, or in patients that have severe peripheral vascular disease or other contraindications to using the leg. You can use the scapula for that. And it's also amenable for 3D printing and for the cutting guides. Now, this is what you all are here for. So how is CAD/CAM implemented for reconstruction after the removal of orthopedic malignancies, where we found the most welcoming home for this technology, as many of the other speakers have noted so far, is in the resection of pelvic malignancies and sacral tumors and sacrectomies. So mostly in type 1 internal hemipelvectomies and total sacrectomies, because the spino-pelvic continuity is disrupted. And we know that vascularized bone is very useful for those types of reconstructions because it lends quite a bit to durability of the reconstruction from a functional and weight-bearing perspective. And this slide is just another video just showing kind of one of the 3D planning sessions for a particularly complex resection. And here you can see the tumor is highlighted in teal, and the patient's lumbar spine is in blue, and I believe his sacrum is in purple. And here, this is one of Justin's cases that I was able to help him with. And you can see Justin here is working with the biomedical engineer to plan his osteotomies and plan the resection. This was a total sacrectomy, type 1 internal hemipelvectomy, and L4, L5 vertebrectomy, an en bloc resection for an osteosarcoma. And in order to recreate the spinopelvic continuity, this patient actually required bilateral fibula flaps that we oriented into a tripod configuration. These were all vascularized bone struts in order to reconstruct the structural integrity of this patient's spine. And here you can see her 1 year post-operatively. The proof is in the pudding. After such an advanced or complex reconstruction and resection, she's able to walk with assistance. And I think that CAD-CAM really contributed nicely to this result. I think oftentimes we think of CAD-CAM as a nice to have tool and rarely as a necessity, but looking back on this case, I think this is a great example where I'm not sure we would have been able to achieve this level of success without CAD-CAM, because it really simplified a very complex case and allowed it to be completed in a shorter period of time with less blood loss. So in addition to using CAD-CAM, and this is the case that Justin touched on during his introduction, but in addition to using CAD-CAM to plan osteotomies, to remove the tumor and to to shape the vascularized bone strut, as you all know, CAD-CAM and computer-assisted surgery is also useful for creating and designing patient-specific implants. And this is a very complex case. This is a patient that had a recurrent chordoma, and he was, due to the locally aggressive nature of the tumor, he'd become paralyzed years earlier, but was reluctant to seek resection. And once he came to us, he was already paralyzed, and a 4-level vertebrectomy was required. And the intervertebral gap was so large that we didn't feel that any off-the-shelf implant would be sufficient. So we thought that a patient-specific interbody cage was needed. We knew that from our prior research that vascularized bone would be very important, as well as the correct hardware in order to have a durable bony fusion. And so Justin conceived of this very interesting implant here that worked out really well for us. And as you can see here, it spans the 4-level gap, and it has a number of unique features that the computer-assisted surgery aspect was able to allow us to utilize. So it's got these plates, these end plates that allow us to secure the hardware to the cranial and caudal vertebral bodies. It has a midsection that's carved out to accommodate a vascularized fibula strut. And then it's got this rail in order to allow the posterior spinal instrumentation to be linked up to this patient-specific hardware. And moving on, you can see here the harvested vascularized fibula, and then how the fibula fits into this patient-specific cage like a hot dog fits into a bun. And then in situ, you can see the fibula with it anastomosed to the external iliac vessels, and then the posterior spinal instrumentation immediately posterior to the hardware. And here's the patient at 1 year post-op, demonstrating good alignment of the hardware, bony fusion, and no evidence of disease. He's in, and this is the actual patient in his wheelchair, sitting upright at home. We've also utilized CAD-CAM and 3D printing to assist us in upper extremity surgery. And this is a patient here with a myxofibrosarcoma of the right diaphyseal radius. And this patient had Parkinson's disease, and her mobility was already pretty limited. And so the last thing that we wanted to do was to compromise her upper extremity function further and prevent her from being able to effectively pronate and supinate. And so instead of turning into a single bone forearm, which could have been something that we could have done, we decided to reconstruct the radius with, again, a vascularized bone. And so here you can see the 3D image of the segmented scan, and then the associated model that was printed out. and the cutting guides that came along with the model, us securing the cutting guide in situ to help remove the tumor, and then the associated single barrel osteocutaneous free fibula flap that we used, fixated with carbon fiber plate, with good fusion and no evidence of disease at 3 years post-op with good function. This is the latest iteration of our use of virtual surgical planning and 3D printing at MD Anderson. The institution has invested considerable resources in creating an in-house 3D printing lab for us. And this is our first patient in which we used our own facility instead of contracting with an outside vendor. It's a 22-year-old male with osteoradionecrosis of the proximal tibia. And he had failed to heal this area with debridement and bone grafting. And so we thought that a more aggressive approach with a formal resection and vascularized bone would be the next best step. And so here you can see the 3D model, the tibia with the resection cutting guide on the left, and then the image of the bony gap after the osteoradionecrosis has been resected. And so using the DICOM files generated from the patient's CT scan, Dr. Karthik Thapa, who you'll hear from after me, was able to use this 3D printer, which is the Ultimaker. I believe that's the one he used in order to print a variety of useful tools for us to help us with this case, both models and cutting guides. And we were able to design a double-barreled free fibula flap to fill in that bony gap. And here you can see him 6 months post-op with incorporation of the 2 bony struts and good healing of the bony gap and healing of the soft tissue as well. So, you know, there's a variety of limitations to 3D printing, namely cost and the additional time required, lead time required as you're planning the surgery, and or especially when we're talking about making a 3D printed patient-specific implant. And there's also some bureaucratic and regulatory hurdles that you have to expect regarding the FDA. Sometimes a compassionate use exemption letter is required to be filed to use some of this technology for these applications. But there's a number of future directions, as some of the of our esteemed panelists have touched on today, using VR and AR to use to help us do these complex surgeries as well. But I really think this is a useful tool, and it's helped us help our patients immeasurably over the last few years since we've adopted it. So I'd like to thank you for your attention, and I welcome any questions in the chat. This is my email if you want to email me any questions. I also have a Twitter account that I check very irregularly. Thank you for your time.
Thanks, Alex. That's a great talk. We're going to jump right into our last speaker, Dr. Thapa. And Alex, you already gave him a nice introduction. He is a biomedical engineer and runs our 3D printing lab. So Karthik, why don't you jump right in?
Sure. Let me see if I have the access. I don't think it allows me to scroll. Dr. Bhatt, do you think you can move the slides for me?
Check it. There we go. I don't have control, I don't believe, but you may have control now.
I don't think I have control because it's all stuck and my mouse is not moving anymore. Kerry, do you think you can move the slides for me, please?
Yep, no problem.
Okay. Are you moving the slides? Because I just see my picture.
I am. Is everybody
Second
seeing?
slide.
Yeah, it's on the from DICOM to 3D model slide now.
Okay, then my screen's stuck then.
Karthik, did it freeze for you?
I,
Did it freeze? Okay, I think it freezed. Did it freeze? 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 Did I think Karthik, you frozen there.
Sorry, Zoom just crashed. Am I back? I think I
Yes, you're back. Can you hear me?
Okay. Can you hear me?
Yes, yes, we can hear you.
Okay, Dr. Bhatt. Thank you for the MSTS group for having me today. Hello, everyone. As Dr. Bhatt mentioned, I'm Karthik Tapa. I'm the PhD biomedical engineer. I'm currently working as a anatomic 3D specialist in MD Anderson Cancer Center. Using this 3D printing technology, I make anatomical models, surgical guides, research tools, jigs, fixtures, and prototypes on daily basis. I'll be talking about the process of making 3D models from the 2D DICOM files. Here in this image, you can see three distinctive phases of a 3D model going all the way from a 2D DICOM images to a volume rendered 3D CAD model to a handheld physical 3D model. Next slide, please. We have multiple 3D segmentation software currently available. In MD Anderson, what I commonly use are these four segmenting software: Metallized Mimics, Osirix, 3D Slicer, and ITK Snap. Of these four software, Mimics and Osirix are 510K cleared, whereas 3D Slicer and ITK Snap are freeware. Well, I would like to say, depending on the application and depending on what part of the anatomy you're segmenting and what type of DICOM files are you using, I choose the software which I need to use for those segmentation process. Every software has its own advantages and disadvantages. Mimics has some amazing semi-automatic and automatic segmentation tools like thresholding, whereas 3D Slicer and ITK Snap have great tools for manual segmentation. So if depending on the type of images, the resolution of images, if the images are good enough, they can be threshold. I usually go with Mimics or Osirix. If I have to do mostly the manual segmentation, I would go ahead and choose a 3D Slicer or an ITK Snap. Next slide, please. To enable conversion of a DICOM images to a CAD model, the first step in any of it is to make a preliminary segmentation of all the regions of interest. Like I was mentioning before, you could either do a thresholding or any semi-automatic segmentation for segmenting out the anatomies within the DICOM files. Here in this image, you can see the masks on the DICOM files on the CT images showing different colors for different anatomies. So once you segment out different regions of interest, these regions of interest are developed or rendered into a 3D model. So that we call it as a volume rendering. Once that is done, you have a 3D CAD model, which can be correlated or visualized on either DICOM files along with the 3D model. So once we have all the masks segmented, we review our segmentation with both radiologist as well as the ordering physician for the accuracy. Next slide, please. There has been a tremendous improvements in these softwares which we use for segmentation. So today we can segment or we can use multiple imaging modalities, and I can lay. So if you can click on the video. So these are two different types of imaging sequences, which I can now register one on top of each other. So I can use a MR scan and CT scan, like Dr. Calderon was mentioning previously. The merging of the CT and MR yielded a better outpatient outcome. So this type of registration of two different images helps me out with segmenting ROIs better. So I can segment a bone using the CT images. I can just threshold out the bone using the CT images, and I can segment the soft tissues using the MRI. And I won't have the issue of registering both the images together. So these software, they have semi-automatic to automatic segmentations too. So this particular video I'm showing here is from Materialized Mimics innovation, where I'm using two different types of imaging sequences and overlaying one on top of each other. Next slide, please. Next slide. So once you have a 3D CAD model ready, so currently we have multiple material options to select for 3D printing. Again, totally depends on the type of 3D printer which you are using and the types of materials which are available within the technology of the 3D printing you're using. So you can range all the way from having a strong rigid material to extremely flexible feels like silicone, skin-like materials too. So based on the anatomies you're printing, or based on the model which you want to create, you can mix and match the type of material which you need, say the color or the mechanical properties. You want it to be extremely strong, rigid like a bone, or you want it to be flexible, bendy, like for vasculature or for muscles. So you can pick different types of colors and different types of materials too. Once you have the segmentation done. So as soon as I select the materials, I send the 3D CAD models to the 3D printer slicing software. So for the CAD models to be read by a 3D printer, I convert the CAD models into .stl file. So these STL files are represented, the models are represented by small triangles covering all the whole model of the anatomy. So these STL files are sliced along the Z axis and is fed to the 3D printer. So these each slice is a tool path for the 3D slicer. So those are the instructions given by a slicing software to the instructions. Hey, you need to draw a line, or you need to lay the material so far in this path. So it's the instructions provided by the slicing software to the 3D printer. Once that is done, the printer does the job. And here in this image, you can see all the three different steps, converting a CAD model into an STL file, and then using a slicing to slice the STL file into layers. Once it's sent to a 3D printer, you get a 3D model. And in the last image, you can see a chondrosarcoma model 3D printed, and it's freshly printed straight on the bed of the 3D printer. Next slide. So once the, as you can see, the whole model is covered with all the supporting material, and it is not how it's supposed to be looking like. So once we have the model printed, we take the model, remove all the supporting parts, and then make it presentable like you see in the next slide. So we do the same with all different anatomies, and then assemble the anatomies to have a one part where so this is one of Dr. Bird's case, and he was using it for the perioperative planning. So before we give it to the surgeon, we do the quality check. We measure, we put some fiducial points onto this model, and we measure the length, diameter, or the angle between different anatomies, so that we have the model 3D printed as accurately as possible, and it straightly correlates with a 3D CAD model. So once the quality check is passed, we then deliver it to the physicians for serving the application. Next slide. Thank you.
Thank you, Karthik. That was a great review of all the work behind the scenes that is necessary to do these 3D printed models and cutting guides, and very helpful in the surgeries that we do. So thank you. I know we're late, out of time. Carrie and Deborah, we were going to do some Q&A, but I don't know if we can, if we have the time to do so. I don't see anything in the chat, but I think people are very willing to answer any questions offline. If you want to just email us if you have any specific questions related to what you've heard today. I think, in my personal practice, these are some of the cases that we've done, and these technologies have been extremely helpful in kind of getting the job done and really helping our patients. So I think we're still early in some of these technologies and seeing the benefits and where we can kind of take these in the future. So pretty exciting. Any burning questions from the panelists, or any comments before we wrap up?
I just wanted to echo what some of the other panelists mentioned about how, the next kind of iteration of computer-assisted surgery is how we can utilize it for soft tissue related problems. And so that is very interesting to me as a plastic surgeon, how you can utilize computer-assisted planning for a very dynamic piece of anatomy, the soft tissue. So it's not necessarily fixed in space to the same degree that bone is. So that's a whole nother level of complexity, and something I look forward to seeing develop over time.
Yeah, I definitely would agree. And I wonder if anyone is currently using, the navigation softwares to look at the soft tissues. I know just on this screen, you see a screenshot of a navigation case, and we focus in on the bone, but the muscle is there. You can see the tumors, and so oftentimes, I will just use that as a guide. Obviously, there's some motion with the soft tissues, but you can start to plan things out and keep an eye on some of the soft tissues in addition to the bones that you're going to be cutting. Any other thoughts from the panelists before we say goodnight? I know it's late in Boston, and Santiago needs to get to sleep.
Thanks for having us. This was great. A lot of fun.
All right. Well, thanks, everyone. Thanks to the MSTS for putting these on. Thank you, Dr. Tyler, Carrie, and Deborah, and the rest of the team. And again, thanks to all the panelists and for everyone joining us tonight. We really appreciate your time, and take care.
Thanks, everybody.
Thank you very much.
Thank you.